Recording in progress.
طيب السلام عليكم ورحمة الله. أهلا وسهلا بكم مجددا في لقائنا اليوم في دبلومة أخصائي رعاية الجروح. Welcome أولا. Thank you very much for being with us in the wound care diploma session, and sorry of being late today. الحمد لله الذي علم بالقلم علم الإنسان ما لم يعلم، والصلاة والسلام على خير معلم الناس الخير محمد. في أحد عنده سؤال؟ Is there any question or any concern anyone would like to ask or have any concern? In our training, in our new training in the wound bed preparation, as you know, we already reach to the for where we are. We already discussed the time as the main framework for us that will guide us the wound bed preparation. So we start with the tissue management. We take the perspectives regarding or related to the infection, and now we are going to discuss the moisture or the exudate management in the wound. So, and later we will go for epithelialization, but before that we will have a special session about the skin health or the normal skin health part, and this will be the following module. While we are discussing the moisture, important for us here to revise the healing process. We discussed the healing process that will start with hematostasis, then the inflammation, and the inflammation is not in a one step that will only appear as a kind of clear boundaries. Rather, the inflammation is going to serve the granulation. A characteristic of the inflammation part of the wound healing is the management of exudate. In this term, we are using management, so it's not a prevention, it's not a treatment. The inflammation will produce exudate. Important for us now to know the nature of this exudate, how we will define it, and know the nature of the exudate. At the same time, exudate is not something bad that we don't want to see. Rather, it's something useful for us that will tell us a lot about the wounds. We don't want to see something in this way. In this wound, you will see the problem that related to the exudate from the wound. Here in this wound, there are consequences of having low proper management for the exudate. Similar for this wound, similar also for this wound. You can see here the slough is originated in the peri-wound area. This exudate harming the wounds, harming the area around the wound. So it's important for us here to learn that this is something that we don't want to have it or see it in why we are dealing with it. So let's start by defining the exudate. What is the definition of exudate? Exudate is a generic term that used to identify liquid produced from the wounds. So we are talking about these fluids or solutions that come from the wounds. Heger in 1982 cited a statement by Paracelsus, doctors from the Middle Age era, and at that time they described the exudate as balsam, and it's originated from Arabic word balsam. And at that time they refer it as a healing agent. Why they are referring to exudate as a healing agent? It's essential in the healing process to know that the exudate is coming normally from inflammation. So it's not something bad or something evil. Rather, it's a vital component that represents for the wound healing process. Also, the exudate come from the wound, it presents the mirror that makes us able to see the wound. So there are a lot of information the exudate will tell us about the wound. This is how we will originate or understand the nature of the wound. How the exudate already informed, how developed, how it's already formulated. The exudate is produced as a result of inflammation. What will happen? The blood vessels, while the inflammation start to leak the fluids outside. These fluids aim full of the nutrients going to help the injured tissue, the injured place, by providing proper white blood cells defense, neutrophils, and many players all will come by this exudate, and the fluids come in, the nutrients for the tissue. And at the same time, it will create an environment inside the wound that will support the developing of new blood cells, and of course developing of or producing the new tissues that will cover the parts in that already lost. So let's come here to discuss the facts related to the exudate. There are a lot of myths. في كتير حكي بيصير على موضوع الإكسودات. فخلينا now let's put the things in its context. Let's understand it in the proper way. In the wound's healing through primary intention, a small amount of exudate will be visible in the opposed edge of the skin, providing an effective seal. This effective seal for the bacteria and debris. يعني الإكسودate, it will work the same like you are opening the tap water, فتح حنفية الموية, and you already with the pipe, with the لي تاع المي, and you are cleaning that area. In this case, the cleaning of that area, this will come from inside the body, aiming to push out the debris, push out the bacteria. So this is apart from a cleaning process that will go on while we are describing this condition. And the narrow border of erythema will surround the inside edges. So within the wound, you will see the exudate will come from the vessels around that area. Together, this will create changes in the pressure that will able to push the bad tissues outside, the dead tissues, at the same time the bacteria, and make this washing out. And this how the main function of exudate works. So this is the part of the changes that will happen while the exudate is there. In this case, exudate can provide vast amount of information about the wound status. It's a mirror that we can see the wound or the condition inside the wound only by looking to the exudate. So I can assess, evaluate, understand the status of the wound only by looking for the exudate, or mainly, or I will rely on the exudate. We are able to know more about the microflora. How is the condition of bacteria inside the wound by the exudate. We will understand the nature, the strength of the infection, if there is infection or not. If there is infection, what is the nature of this infection? What is the nature of cytokinase, proteases, in biochemical markers reactive to the oxygen status? All will appear clearly for us why we are looking for the exudate. Now, we will discuss the current evidence related to the exudate, but the nature of science in the wound care is still developing. So there are maybe also in coming future, a lot can be described from the nature of exudate, mainly now with the new AI applications that start to analyze the characteristic of exudates in different machine learning mechanisms. Perhaps in a time of the information that we will take it now, the information that will be built on the therapies that will prevent the wounds from transferring from acute status to the chronic status only by understanding the exudates, because we can redefine the nature of exudates. We can redefine the biochemical condition inside the exudates. In this case, we will stop the transfer of status of the wound from chronic from acute to chronic, or from chronic we can reverse it back to be similar to acute by manipulating the exudate status. And this is apart from continuous exudate analysis and feedback. There are different studies and researches focusing on this way. Let's start here to know in general what are the components of the wound exudate. What are the solutions that come from the wound, what already contains. First, you will see the sodium, potassium, chloride, urea, creatinine. All it's come from the serum, come from the plasma of the blood. Also, it will have amount of glucose. It's lower than what we have in the body, lower than what do we have in the blood itself, because this is apart from the consumption from the neutrophil. But this will tell us that the exudate will help the neutrophils to stay alive. Also, the discoveries of the cytokinase impact. Do you remember when we discussed the many players? All the many players will come to the wound by the exudate. So the cytokinase, in this case, we remember the interleukin, الIB والIL6, الTNF beta, interferon alpha, and this all apart from the many players that will help us to stop the progression of infection and at the same time supporting developing of new tissues. Leukocytes, initial levels of the whole blood, that differs in the count but it starts to work. Lysozyme, which will be elevated levels compared to the serum because it will help to destroy or kill the bacteria. Macrophages and MMPs with all consequence, all the issues of the MMPs, already the state, the location of MMP, it's come in the exudate. So from this nature now we will be able to determine the condition of the wound by knowing the concentration of MMPs, for example. We now have an information that increase the level of MMPs mean the wound going for a chronicity. That's why the new products say that, okay, even in a chronic wound, if I am able to lower the MMPs level, so I push the exudate characteristic to be acute characteristic. Also, this is the philosophy or the paradigm of thinking in the controlling of MMPs on the exudate. Microorganisms, neutrophils, and the protein, as already known. The importance of exudate, it will give more flush, the cleaning. It will support the cell migration to that area, support epithelialization, and it will be healing factor savers as we already get. Plasma from which exudate is derived all the necessary ingredients that will come to the wounds. There's oxygen, nutrient, tissue, organ to the body. The same, it will exudate on its way to the surface, which make a layer that will prevent additional bacteria to come inside or make like a stop point or checkpoint, so not all the bacteria will be able to penetrate. At the same time, it will reserve the oxygen from the direct concentration with the outside environment. So this is something that we should take it in consideration also. What do we have also inside the exudate? Rather than what did we discuss? We will see fibrin, platelets, and these four clots. In macrophages with all white blood cells with all types. So we'll not come here to discuss the differences, but all with PMNs and lymphocytes, macrophages. Okay, so all this will support the immune defense. Microorganisms, plasma protein, albumin, globulin, fibrogen. Also important that we will note inside the exudate lactic acid. And this can be also have a different biomarker. So there are now a new types of dressings that can detect the MMPs by labels that will be put in the wounds, and another dressings that can detect the lactic acid level inside the wound by the same. هي عبارة عن small sheet that when you put it inside the wound, the color change, and this will give you an indication about the concentration of lactic acid or MMPs. Glucose, ingredient salts, growth factors, and the tissues and the MMPs. And this is part from the concentration insights. Now, for me, what I want in this collection? Assessment for volume and type of exudate. And this is what we agree on, right? If I want to produce exudates at a regular, insignificant level, dressing only need to be changed infrequently. This is important concept because how we will estimate the amount of exudate. The exudate amount is be controlled by the amount of fluids or liquids inside the wound. So at the same time, by the size of the wound. So maybe we have larger size of the wound. We cannot see the exudates to be high, but already producing high level of exudate because of the wound size, and vice versa for the small wound. And this make a challenge for us, challenge for the wound care, challenge for clinicians. So how we will describe, or what are the amount that we will describe the amount of volume of exudate. For the volume, we are referring to the needs of dressing to be changed. When the dressing that we are using, either you are using gauze or negative pressure wound therapy, whatever, all within all these variations, you will describe the volume of the exudate based on the dressing that you already used. And this will help you or help us to determine the best solution or the best treatment protocol in this case. Also, the type of exudate, the color that you are seeing inside the wound. So you will go for the color and the nature of exudate to describe the consistency, the thickness, the color. Is it transparent, white, yellow, green, black? So all this will help you to know more. Bloody. It will assess the monitoring healing. A judgment can be made based on the choice of the topic and application. A healthy wound will generate a small level of moisture, and this is what we looking or hope that this is the level that you will reach. As in the optimal level of exudate required to facilitate the healing process is under determined. هذه يعني موضوع كثير جميل for additional research about determining the exudate amount per cubic centimeters inside the wound, كل سنتيمتر مربع. But this is still having opportunity for development in research. Until now, the exudate volume traditionally characterized as light, moderate, or heavy. And this approach subjected to leader problem with the dressing selection. لأنه والله ممكن can be that what do you see as a light, I see it as moderate. What do you see as moderate, I can see it as heavy, right? So there are subjectivity in describing the amount of exudate. Betts Johnson, one of the key figures in the wound care, and he developed the famous tool in assessing the wounds, attempt to improve the situation by developing number of more detailed descriptors. They say that reducing the subjectivity elements in the assessment is necessary. يعني احنا لازم نتفق على طريقه معينه. لما نيجي لقدام we discussed about the accreditation part of what the accreditation do. They will give the same wounds for two staff. They ask the staff to assess these wounds, and they will at the end come to say that are they describing the same wounds in the same way or in a different way. So with Johnson, what did they do? They create additional ways to describe the status of it. They said, Wallahi, I will describe it as none if the wound tissue dry, scant if it's moist, small, and this come here to say that in the case of this wound, the wound tissue wet, moisture evenly distributed in the wounds involve 25% of dressing. يعني لما اجى الوند كير يغير الجروح كان ربع الدريسنج اللي محطوط قبل هو الويت. When the wound care come to change the dressing after 24 hours, only 25% of the dressing were wet. Wallahi, you are using gauze, so we are discussing about the situation in gauze. You are using foam, I'm talking about Betts Johnson. Then 25% from the foam. You are using negative pressure, so you will go for the tank of the negative pressure, pump itself, then it filled 25%. And you will describe it as moderate when the wound tissue saturated, drainage may or may not evenly distributed in the wound drainage, and it will range from 25% to 75% of the dressing on the same previous kit. Large معناته احنا we are talking about more than 75% of the dressing already filled with exudate. So based on Betts-Johnson, you will describe it as well. So we have none, scant, small, moderate, and large. Instead of the previous, يعني قبل 97 before 1997, we described the wounds to 3 levels: light, moderate, and heavy. Now, after Betts-Johnson, the description of the exudate in the wounds converted to be on 5 degrees. Now, currently, even this one also still have some challenges. ليش the challenges happen؟ في نفس السنة the same year لما Betts-Johnson طلع هذا recommendation، عندنا لامك and نيلسون in 1997, the same year after Betts-Johnson, when they already announced that, have shown that the burn produced 500 grams per meter square per day of exudate. And this also come with another evidence, stronger evidence, come from Thomas, 1997, who already measured the exudate come from the venous leg ulcer to be raised from 4,000 to 12,000 grams per meter square per day. طبعا هو الفينس leg ulcer always is the heaviest exuding wounds. دائما الفينس leg ulcer هو اللي اكثر بيطلع exudate. معناته بهذه الوي they come to problem or dilemma انه والله even this way of description of exudate still يعني did not describe. حكوا انه there are additional characteristics can influence the exudate. يعني الاكزوديت ما بقدر اطلع عليها بس على حاله الجروح اوقف هون. As we described before, we are looking for the patient as a whole, not a hole in the patient. منها الإديمة, منها systematic infection. So all this can influence the exudate, hypertension, heart failure, and so on. We have yet to gain a full understanding as to why some wounds produce exudate more than others. يعني ممكن يكون في two patients, the two patients 4th degree pressure ulcer أو venous leg ulcer in the same similar condition for the wound, but the amount of exudate different. But what do? They come into exudate analysis to indicate its connection with the protein loss. زي ما حكينا قبل شوي, exudate already contain protein. So, high amount of exudate mean the patient is losing protein in high level, and this can means additional significance level, which means that when the patient lost a lot of protein, the amount of the protein they have it inside the body will start to be low. This low of exudate means the osmolarity inside the blood will be changed, and the amount of fluids will get out from the wounds will increase. فبندخل بحلقة مفرغة positive feedback. More exudate, more protein loss, low osmolarity, so more protein loss, more exudates, and so on. So important for us here to probe this with. This all make Betts-Johnson to redefine the previous description for the exudates to add additional description for the type of exudate. No, Allah, we should describe the volume and the nature of exudate to be thin, bright, red water, and they call it blood. Serous sanguineous, which is thin, watery, pale, red to pink, and this will give you indication about the presence of blood or the nature of the blood. Is it clotted blood or not? Serous in the thin, watery, clean. Purulent in the thin or thick, opaque, tan to yellow. In this case, we are talking about changes in the color which reflect more pressure on the white blood cells, more protein losing, or full purulent, which means already adding to the color change, either yellow or green, offensive odor, which means aerobic bacteria infections such as Pseudomonas or gram-negative bacteria, Escherichia coli, and so on. In the same study, the Pitts-Johnson, they put here to highlight the differences between acute and the chronic exudate. In the acute, the fluids will be positive for cellular proliferation, doesn't damage very wound skin area. That's why when you look to the edge of the wounds, post-operatively, the edge of the wounds will not be affected by the solutions or the creams that while you are doing the dressing. However, the الجروح في the clean surgical wounds will not be affected by any exudate come from the wound. This is different than the chronic wound, while the first point of contact that you should evaluate and look for it is the peri-wound skin area or peri-wound area. That because the nature of exudate come from the wounds will burning or making complication to the peri-skin area. Also, acute area will be fibroconnected intact, neutrophils nature, and fibroblast mitosis present. And this all will support us in differentiating the chronicity of the wound and the nature of our work within this condition. The dynamic nature of wound exudate content is demonstrated if the wound becomes infected. Or directly, the exudate will be the first things in the wound that will tell you the alarm of presence of bacteria, presence of infection. Microorganisms be considered as exogenous component that will make the nature of exudate change and direct the production of production of exudate increase. For the production of exudate, it will come with us in this way. There will be an amount of exudate in the wound, and let's say that this amount of exudate will come on this level. With the onset of infection, when it starts in this way, so the exudate amount will start to be increased, and the nature of this exudate will be changed. This will be stayed until the onset of biofilm. And in the biofilm, the exudate amount will be reduced down. And with the chronicity of the wounds, after taking of time, the body will start like losing the hope or unable to defend the biofilm. Do you remember when we say that broken up the biofilm, meaning most probably increase the amount of exudate again, which means we send back the wound to the previous condition, and that means we are on the correct path for correcting the healing process itself. There are also rationalization for this phenomena and hypothesis, which is associated by the VEGF or vascular endothelial growth factors, which control the permeability and hence exudate within the epithelial and the blood vessels in the around wound area. هذا الفاكتور لقوا انه والله لما تيجي البكتيريا في الاول بيزيد هذا الفاكتور، فبالتالي بتزيد الاكزوديت. عند حد معين بعدين هذه البكتيريا شو بتعمل؟ تتحول لبايوفيلم. With the biofilm, amount of exudate will be reduced. So the controlling of this process, exudate, a direct onset of infection will mean additional exudate, then the biofilm will reduce the amount of exudate, and that's why when we describe the destruction of the biofilm means the exudate will be increased, and this is positive signs and not negative signs. Why we are talking. Let's go here how we will manage the wound exudate. Let's start here by the goal of the exudate management based on the wound bed preparation. So we will go now for the theory of time, wound bed preparation, to look exactly what the theory guide us while we are dealing with M as management. The theory said that we want to maintain a moist wound environment. So it's not dry that will lead to granulation to be done, the granulation tissues or vaporization. And also we don't want it to be in a wet, so the cells unable to produce new cells or support the additional infection to come. And this exudate management The second objective is to prevent maceration. And we describe the maceration during the assessment, which is overhydration of the surrounding skin. Just here to revise it. Why we don't want maceration mainly in the epithelialization? Why? In general, how the cells already divide, this is the cell of epithelialization, epithelial tissue or granulation tissue. So this is the nucleus. Normally, they will start to be divided by the asexual division, while the nucleus here, they will have the centroles to come on this area and one centroles in this area, and will start to push out the genetic material, which will end by the famous shape that we'll have it here, that we have here centroles catching the genetic material, and at the end we have two cells. So this is the normal way. In the maceration, because this cell had been pushed to take more fluids than what able to, so the size of cells had been expanded, larger cells, which lead that this centrole is unable to do this function. So in the case of maceration, there is no cellular division. So we don't have ability to produce a new tissues, which means that we are unable to lead these wounds to be closed. So our responsibility is to prevent the maceration. Objective number 3 is control infection and odor. We clear it about it and promote optimal wound healing condition for the new tissues and enhance, of course, the patient comfort, because patient comfort means higher quality of life, proper wound healing condition, and so on. And these strategies will help us to choose the right dressing. This is the concept. يعني at the end, والله احنا we keep talking. Okay, طيب, والله what dressing that I should use? What is the best dressing that I should go for? And so on. And of course, monitor and reassess, so the re-evaluation for the peri-wound area. And this peri-wound area, the proper management for the peri-wound area means that the wounds either going for proper healing or at least stop the deterioration of it. So let's start here to discuss about the dressing. The traditional thinking describe the proper exudate management by absorb and retain exudate. والله احنا بدنا نستخدم dressing that will remove this exudate from the wounds and keep it. So this is what they call it traditional thinking. Certain key performance characteristics require إنه والله we want to remove this solutions and keep it to not come back again to the wounds inside. هذا اللي اسمها absorb and retain exudate. بس صار في عندي بعض المشاكل على المتحدية فيها واللي أدت ل different types and categories to be developed over time. في عندي الإيشوز الأولى it's absorption, gelling, retention, and moisture vapor transmission. Let's see how this type of dressing already developed and come to be. This information may not always be based on accepted independent test methodologies, important for us here to know. Rather than I built this based on the evidence, being this evidence come from the manufacturers, how they describe their own product, and how they make comparing in the journal. So until now, there are some gaps in the studies that already published in the information that we are talking about, but this is the most, let's say, independent scientific ways without coming to the details of laboratory data or pharmacocopies and this detail. So we'll try to simplify the information to the best nature. The first type that we will take about this is gelling absorption. Gelling, it's a symbol. They will put a material in the dressing that will absorb the fluids and transfer this fluids to be in the gelling shape. In this absorption, it will interact and make the exudate to be transferred from liquid status to gel status. For example, this is what make the alginate, as you know. اللي هي carbohydrate polymers gel according to the portion of urinic acid and its composition. Alginate, when it started at the first term of alginate, it's come from the seaweeds. So in this case, they take the seaweeds and they use it in this way, and they announce it, oh no, wallahi, when we absorb the exudate that will come to this dry seaweed, it will be locked inside, so this dressing will not allow this solutions or exudates to come again to the wounds in any. And then later, they discover that if we put on this hydrocolloid, wallahi, silver, so in this, after releasing or absorption, you will start to release the silver. In this case, we come to use the same dressing for two different purposes: control the infection and control the exudate. And this is the same idea that comes within the hydrocolloid gel. Hydrocolloid, anyway, it comes before the gelling techniques, but it lead and serving each other. And this, as you can see here, at the shape of the seaweeds that live inside the sea. So it's used to have this amount of, or living within the amount of solutions, and so on. They come to this mechanism. But there are some challenges facing them while they are discussing about the alginate. There are different types now of alginate. There are some challenging come within this using of alginate, mainly because the alginate, when it's already absorbed, there will be hard or difficulties while we remove this dressing from the wound to make a new dressing. So they come to say, wallahi, we also want dressing that easy for us during the application and provide additional help to the surrounding area. When they start to use the alginate as gel, one of the main challenges that they use it, wallahi, I will use here alginate. فهذا الجروح عند الجروح. أنا put alginate. But because of the nature of alginate, this area is not exposed to the exudate, because the exudate comes from the wound. But the nature of exudates, by the osmolarity, make the exudate to reach this area from the dressing. And from the dressing, this area starts to wet the peri-wound area. So it appears to be a problem or challenge within the exudate. The second challenge with the exudate, mainly the initial or the first prototype for alginate, which is the hard to be removed. So they start to put like layers around the alginate. So in this case, we will be able to remove the alginate or make the dressing easy with the and so on. And some particles of the alginate can become inside and stay there, and it will be a source of infection or a base for biofilm. So it will complicate the situation inside them. So they come here to say that, we want also, and they discover also the fluid retention as a challenge. The exudate after time, the exudates absorb on a time, then it will start to release the exudate again. And when it's reached to the osmolarity level, so it will start to read the part of the exudate. In this way, they demonstrate, or the studies developed the new technologies that learn from the previous experience by the hydrofiber technology. Hydrofiber technology is apart from technologies that learn from the challenges come from the alginate. On the same time, it proves additional benefits rather than the alginate, that ability to lock the exudates even under compression. In this case, the hydrofiber prove additional clinical effectiveness, and they redefine the nature of it. So they use the same idea of the alginate, but they redefine the nature of composition inside to mimic the alginate without the negativity of retention of the fluids, and at the same time supporting the peri-wound area and easy to be removed while we are doing the dressing. So the contexture of hydrofiber better than the alginate while we already the dressing and support additional absorption. The third ways of these products, it's a moisture vapor transmission, and they use it or develop it in a way that we will use a dressing that will allow for exudate evaporation. So in this case, the vapor transmission or the moisture transmission will go from the wounds to the environment upstairs and will block the back door. So only one way for the exudates to come and go inside. In this case, it will give like a gate or exit for the fluids to get out from the dressing itself. This methodology had been successful over different material that already used. It started to be on the simple mechanism by the bandage or gauze. So the gauze, it works in similar to this mechanism that absorb and make the vaccination, but the problem in the normal gauze that unable to lock the back door or lock that from outside to inside rate, and that lead them to work more to develop in hypo or in parts of in foam dressings or the antimicrobial foam dressings that able to make these layers so that the evaporation will get out from the dressing itself. But there is a problem also appears for them. So we discussed until now the gelling dressing or category of dressings under the gelling, زي supra absorbent dressing, زي يعني different names now we have a third name, but all working as gel. The second types اللي هو حطينا الالجينيت والهيدروكولويد. The third one was hydrofiber. Now antimicrobial properties appears as a problem with the vacuumation. إنه والله أنت you put the dressing on the wound, and this dressing designed to lock out the exudate, allow for some evaporation for the water. But when we have this evaporation for the water from the exudate, we will have additional amount of bacteria. طب هذه مشكلة. So we have now critical colonization. The bacteria start to live inside the dressing itself. So they start to create mechanisms or additional ways, as you remember. إنه والله let's do crystalline silver. Let's put iodine in the foam. Let's put silver in the foam. But this silver, different than the ionic silver, it's crystalline. So it will protect the dressing itself, or honey maybe. So there are different mechanisms work in this way. This study tried to define and revise this mechanism that based on the efficiencies of such dressings that able to detect the infection inside the dressings. So in the infection detection, rapid detection pathogens and the wound exudates, bionucleic acid, lactic flow, and immunocy, and they analyze the concentration of Pseudomonas aeruginosa, and they come to say that when the dressing should be changed based on the concentration of lactic acid that come or make an indication for the Pseudomonas aeruginosa and other type of infection. Okay, so this is the study. In this case, let's here to summarize what do we have in the nature of wound exudate or wound management. Hydrocolloids, now it's clear. Foam dressing, here we have the categories. We are talking about hydrophobic foam. That means we're talking about special type of foam that will have inside the dressing chambers, and these chambers will make the balance. So the small chambers, and when the small chamber is filled, they will start to give the water to the bigger chamber, and this bigger chamber can be moved and release the exudate or some amount of solution to the dressing. And usually it will be applied for moderate to heavy dressings. And it's variant in the time. Now, I'm not talking about all foam dressings are the same. There are foam dressings variant in the type. What are the variations happen? Well, the first one, is it acrylic or not? Is it sealed or not sealed? The second one is the ability to absorb of the foam dressing. The third one, ability to keep the fluids under the pressure. So this information, all you can take it from the manufacturers. When they already announce or launch the new products, they will launch this information within this dressing. يعني والله, I wanted to compare foam dressing from this company or this company or this company. You will choose based on the needs that you have it and the information that will come based on the studies already up. We discuss about the alginate and the hydrofiber. Now the goes as a part from standardizing. They start to standardize all this information based on the goes. and the transparent film. So the hydrogel, there are kind of gelling factors that will transfer the wound exudate to be a kind of hydrogel, but there's still debate in the exudated part. Transparent film, supra-absorbent band, and the negative pressure wound film. طيب والله كل هذه الانفورميشن but you give us more information and now we are confused. يعني اوكي انا شو استخدم؟ انا بالاخر عندي مريض شو احط له دريسنج صح؟ ما this is the simple question. Unfortunately you cannot come to this simplicity way until you understand all the details around it. Then you will make the decision based on proper understanding of the nature of the change. Famous study اللي هي based on a meeting report come among the consensus of experts of international wound care specialists all over the world in the one of the international wound meetings اللي هو international meetings done each 4 years one time, so it gives a chance for researchers to investigate the perception of the people working in the wound care, either in clinical or in academic or in the laboratory. So this will be an opportunity. And they report this in the Wound International Wound Journal about closing the gap between the evidence and clinical practice. Consensus report on exudate management, and they analyze the performance and the feedback come from 85 participants in this report, and they come to conclude that there is a great deal of evidence about the importance of exudate management of chronic wounds. So we are all agreed now about the importance of management of exudate. صحيح؟ يعني كنا متفقين على الموضوع. And within this project, they take how those 85 participants or 80 participants understand the situation of the wound, to build their own decisions. Anyway, they came from 19 countries until they come to know exactly how they are thinking on the best dressing to choose. Basically, the choice that healthcare professionals make it regarding to the wound treatment will significantly impact the patient experience. And they should check for the quality of life and the impact of healing time. Every healthcare provider's outcome goal should be fewer days within the wounds of exudate. احنا الأولوية تاعتنا we don't want to see the exudate days in the wounds to be extended. So as much as قدرنا نقلل هذه days, that means we are on the right track. And they said the factors that they will ask themselves before choosing the most suitable dressing for the exudate management. They will ask first about comfortability of the dressing. لأنه أنا في عندي في exudate management, I can start from hydrocolloid to negative pressure. So I have variations. But what about the comfortability for the patient? Is it suitable to be left in a place for a long duration? والله في exudate. In general, I want the dressings to not be required changed for less frequent. صح؟ يعني كل ما كانت الفترة اللي بجلس فيها الدريسنج على الجروح أطول كانت النتائج أفضل. More days on the dressing, that means this is better for economy, for my time. But I don't want to give a chance for the bacteria within this exudate to make a additional problem inside the wounds that lost me that precious time to make proper decision to support the wound. So what is the time that we already accepted? In the infection part, we discussed that there is no efficient dressing less than 24 hours. And now the evidences from the clinicians say that not more than 3 days. Some products announce it from the manufacturer, and we can stay up to 7 days. But for the clinical constructions, and keep the dressing for 7 days, that means there are a lot of changes could happen inside the wound that we don't want to see. And in the exudate, the chance of leakage between the dressings can be higher. The dressing had the amount of exudate under the pressure can reach the maximum. ليش هذه important? In numbers that come from the manufacturer, taking the ability of the dressing to absorb in optimum condition. هم بياخذوا الدريسنج على المختبر بدلوه تدليع. they will put exudate in amount. They will not make any pressure on the. But the nature of the patient life doesn't support this one. صح؟ Mary position, walking, still a human. Nature of temperature. الآن في عندي evidences about changes in the ability of exudate to of dressing to deal with the exudate based on the environmental temperature. كمان التاني wound area need preventive skin protector أو لا. Is it easy to be applied ولا لا? Is it cost effective ولا لا? So all these questions, understanding of this question will make it able the clinicians how they will make the proper or suitable decision for the wound dressing solution in the management. They made comparative analysis for the ability of the moist wound healing produced to absorb blood. And has not been previously. في عندنا الآن في دراسات للإكسوديت. الآن على مستوى العالم, as I know there are 3 or 4 centers only all over the world, they produce the human exudates for research. يعني في موجود واحد في جامعة طوكيو يونيفرسيتي، واحد موجود في بريطانيا في إيرلندا في they have centers. وall other companies they take هذه الإكسوديت عشان يعملوا ريسيرش على الوونز على الدريسنج نفسه. واحدة من هذه البارتس تاعتهم انه they start to discuss انه ليش ما ناخذ على البلازما for example. So the studies can get variations انه when we come to compare. لانه انا لما احط بلد انا بتذكر ايام يعني في المستشفى one of the company representative he bring water and he put the water in the dressing. I see how much the absorption. Okay, good. It absorb water, so take it to Sabak or take it to technicians. I don't deal with the water. Now we are dealing with exudate. The nature of the patient, pressure, nature of exudate itself. يعني one patient with a transparent exudate, even if it's heavy, still it's transparent. Comparing to other moderate maybe exudate, but it thick exudate with a slab, green, full, smell, and so on. So this should be taken into consideration while we are selecting the dressings about it. The one of the study about, for example, the ability to compare the dressings based on one standard, which is an MWH, or the ability to absorb the blood. But for example, they discovered in this study إنه والله ability of إذا حطينا include 12 fiber dressings, alginate hydrofiber, and 15 absorbative من البوليوريثان والhydroactive combination products. But they come to conclude إن البوليوريثان foam والhydroactive foam better than alginate والhydrofiber in the absorption in this 3 degree. But still, these studies all should be taken into consideration. Look for another study. They discovered that in hydroheal algin film, which is bought from the fiber dressings, منه مثلا موجود الكيتينوفا الجينيت، الكالتوستات، الراستورز، كلهم هذول بارت. They are able to absorb up to 35 grams of blood per 100 centimeter dressing. والlatest absorbent بتاعت الاكواسيل كانت 21.5 جرام لكل سنتيمتر مربع for cubic centimeter. The integrity of the fiber dressing varied marked from sorban, which is designed by the Coroscore, the Sapsorbs, Alginate. كلهم هذول طبعا يعني names of products that already participated in the dressing that we are referring about. But they come to conclude that the rate of absorption for all fiber dressings in general was rapid, and there is the differences between them, even if it's come in the lab, it cannot be a clinical significant to say that this is what we are going to determine about the nature of this. هذه الدراسة اللي أنا بشير لها absorption of blood by most healing dressing, but in general in the conclusion they come to say that يعني أنا أخذت نفس العبارة من نفس الدراسة. 12 fiber dressing alginate and 15 absorbed polyurethane form hydroactive combination products. And they confirm the sorpagland, cotonoval, caltostat, إلى آخره all of this. This is the result. What you can see here differences per number. يعني هون هذا Exudate for Smith&Nephew, Alderant for Johnson Johnson now 3M, the Aquacell, the Comfort, the Comfit Syrup, Coloplast. So they try to take the rest of the Calscara, Hollister's, sopralegault, Hartmann, and so on. I think this now is not produced anymore. Anyway, in this case, you can see, yes, there are differences in the acidic ability of the exudate, with the calcium alginate, physical constructions, and the feedback and the negative consequence. But in general, there is difference, but this difference did not be reflected in the clinical let's say about the clinical implication or clinical significance. يعني في فرق في المختبر بس على مستوى المريض ما لقوا نفس المستوى من الديفرنسز بتاعتهم in the ability to absorb. تبغى انا بحكي بس على الابسوربشن. In the same study, they differentiate between Allegan, biotin, Combiderm, Coltonova foam, Exudate, fiber, etc., and they make here the composition, description, the types, and so on, to come to conclude that it depends all on the three main conditions: the nature of exudate itself, in nature of the patient daily living with other comorbidities, and the wound care decision. And on the other hand, it's a clinical decision. What they are doing now, what they are supporting, what are the studies will lead us more now toward the AI and the wound care integration ما بين استخدام الذكاء الصناعي وال واحدة من هذه الدراسات, one of يعني really I enjoyed the reading of this. They said about wireless and closed loop smart dressing for exudate management on demand treatment of chronic wounds, and they here create application اللي هو ال IWT أو integrated wound dressing. In this way, they wanted to close this gap. إنه والله I will come, I will tell this scenario what I have, the available dressing that I have in my hospital, what is the condition of the patient, and then this will help me to choose the best based on the condition feedback that will come of the patient. And they have the monitoring and wearable way. هي عبارة عن small piece. This is not converted to be commercial, but this is could be happening soon. عبارة عن wireless صغير will be put on the wound. قطعة صغيرة will be disposable, and they have number. This number will be downloaded on a smartphone or electronic medical records. ممكن على حكيم, ممكن على ستيرنر, any electronic medical records in the hospital. And it will start to study the nature of analysis of the exudate, the amount, and it will come to conclude better dressing choosing for this patient. So either you will go for negative pressure or hydrocolloid based on the nature of dressing. It studies on these devices, now getting good results on the rat, and the study already published 2023. Now for 2025, maybe the next year or the year after, we can start to see a prototype for this one in human application. So what we are doing here, it's not only just a dressing. We are dealing with more than one aspect or one category on the dressing itself. And important here to notice more about the negative pressure wound therapy. I think all of us now are familiar with the negative wound pressure therapy. It's a type of device that will keep the wounds in negative environment, and there are two benefits come on the negative environment. The first one, the exudate will be sent out, and this negative environment will push the blood to go inside. So this is similar how it's already come. So the definition of negative pressure wound therapy, I want here to stress that as a professionals, we don't use the back as referring to the negative pressure wound therapy. In fact, it's commercial name for a company, but the treatment name, it's negative pressure wound therapy. One of these machines is vac, and they take the vac from the vacuum, but the people call the easier of the vacuum. But it's a negative pressure wound therapy. It's a technique that will be used to control suction, to promote healing and management of the exudates and so on. There are two types, either by foam or by gauze, and the differences between them are the clinical differences between them. It's not high, so both can get into the same result in the end. There are the three types now. Here it's written two types: continuous and intermittent negative pressure, and now we have اللي هو flush. So we have either negative pressure that will keep this negative pressure all the time, so the exudates will keep it out, intermittent negative pressure in and out, and there will be cleaning or flush. The history, so this is the BAC, this is referred to specific type, before was called KCI, now a 3M, so this is commercial name. I will talk about negative pressure wound therapy system, so this is the professional, academic, legal description for this kind of thing. The first concept for the negative pressure wound therapy started by 1800s. Then the big achievement happened by Dr. Michel Marcus in the Wake Forest University in 1989. So this is a big step. There are a lot of talking here happened between 50s and 60s, but the major step happened in 1989. Then in 1987, the KCI produced a commercial device, and after 2000 now there are wide spectrum types, portable, changes in the shapes, and the differences in the amount of pressure that will be produced. And so what is the mechanisms of the negative pressure wound therapy? It will do macro deformation or visible physical effect. So it will, the foam will contract, and this contracts create under pressure, and this means there are pushing on wound contraction inside the wound, so the smaller of the wound size will happen. And there are other additional effects of the negative pressure, what they call it micro deformation, which is the sucking of the blood. So that will push the blood to come inside the wound. That's important here to know about the angiogenesis. In the negative pressure wound therapy, the angiogenesis or building of a new blood cells had been done under pressure. يعني الشرايين الدمويه اللي تكونت اثناء النيجاتيف بريشر تكونت تحت ضغط انه لازم تتكون. So in many school of thoughts for the doctors or plastic surgery, they will remove it again after it's already developed. They just say we will just only use it for negative pressure purpose as exudate management, not as pushing for the proliferation. In many studies, they say the nature of proliferation tissues come from negative pressure still questionable because it built under this pressure. But anyway, at the end, there are improvements expected to happen. So negative pressure wound therapy sucks out excess wound exudate. This is why we are discussing about it. So negative pressure is used as exudate management. It's not as in control infection. It's not for granulation. It's for exudate management. And because of this absorption will happen, it will reduce the interstitial edema, improve local blood flow, and of course, it will remove the bacterial load as a result of sealing and sucking the exudate from inside. This is the issues regarding to the improved perfusion, because it will push the blood. Have to, because of the negativity, more oxygen nutrients, so the granulation tissue will be formed, and the result that we will have additional tissues that will be developed in the wound bed after using the negative pressure. Sealing means barrier against infection, reduce the infection amount, and also support the exudate environment to get out, so the bacterial burden will be less. In general, the actions, this is the summary of the actions. So the negative pressure wound therapy will do macro deformation, fluid removal, enhanced blood flow, and moist wound environment. Each step will lead for something different. So macro deformation stimulates tissue regeneration. Anyway, this part also, I mean, we stressed here on this way. Usually there are 2 or 3 questions will come on the wound care board, usually on the American wound care board. This is the table can summarize what are the specifications or benefits of the negative wound pressure. Third, when we will use it in the acute wounds, only the surgical exuding wounds, for the partial and full thickness burn, for the neuropathic ulcers, venous or arterial ulcers, trauma wound, and the post-flap or mashed graft of the wound. So this is indication for it. How you will apply it, this is simple. And I know a lot of you already familiar with familiar with using of applying the exudate, the negative pressure wound therapy, but this is just on a revision for you here. This is the video. So this wounds already, they decide that there are amount of exudate that they should apply. So the assessment done. So this is foam dressing, one type of the negative pressure. Important that to not leave any piece of foam on the purulent area. Never, and this would be fatal. And this foam, it's not the same form of absorption. This is just only for transportation. So it will not absorb. So that will lead for additional exudate on the purulent area. Without coming to a lot of details, this is how we should seal it inside. So the foam will be touched only the wound bed inside itself. And in this case, after you put it, then you will seal it and you will cover it. So this one should be cut it and then covered by a Tegider. And then after that, you will open an axis for the device and you will apply the device over the environment that you created. And you can see here that this is the part of the dressings. Then it will be put in this way. Until it comes to this shape, this. And then there will be a small cuts that on this system and applied to the device. And this way that will be monitored by Exudate. This is all for, it's an easy module. It's direct, goal-directed module that will directly tell us what are the importance that you will have it while you are dealing with the exudate management. It's all full and package. There are a lot of variations on the dressings that apply on these categories, and it will help us to know more about the wounds itself. Important for us to prioritize and make the priorities for what are the goals and objectives that you will follow while you are dealing with such wounds. And we already covered the negative pressure wound therapy. Is there any question or concern?